Welcome back to Inside Athletic Training and our Tales of the Tape series detailing the ins and outs of Tommy John surgery with experts in the athletic training and sports medicine field. On this week's episode, we'll dissect the ins and outs of the actual surgical procedure, taking a deep dive into the innovative treatment and recent advancements of this pivotal procedure that has lengthened the career of many in Major League Baseball. Joining us again is Dr. Chris Ahmad, iconic New York Yankees head team physician and Tommy John surgery expert. With years of experience and a wealth of knowledge, he'll guide us through the intricacies of Tommy John surgery, the early years of the procedure, and the cutting-edge techniques used today. Don't forget to tune into next week's episode, where we sit down with Ron Porterfield, Director of Player Health with the Los Angeles Dodgers, to discuss in great detail the rehab process after undergoing Tommy John surgery from the perspective of a Major League Baseball athletic trainer. Enjoy the show.
So you mentioned, Doc, the interprofessional, the multidiscipline type approach that obviously Dr. Jobe had instilled in you and that you continue to have as head team physician for the New York Yankees. So, let's dive into when we're talking about the surgery and the evaluation and the return to play and that entire process. So when there's a player that's coming to see you with a sore elbow, and whether it be an acute one pitch issue or maybe it's more of an acute on chronic, what conversations have you had with your athletic trainer or your medical coordinator prior to the exam? And then what kind of information do they give you to help you and your staff be prepared for what you're about to face?
Yeah, great points. So athletic training staff has a great relationship with the players, and some players may have been expressing some lower level of symptoms. Hey, I'm a little tight. Can I get my forearm worked on a little bit after a game? And so trainers come to know their players well, and some players, they need soft tissue treatment. Other players, it's rare for them, and if they come in for soft treatment, their spider senses go up. So the first thing that happens with a player who gets injured, let's just say within the Yankee organization, is I have a conversation. I'm alerted to the problem by the training staff, and they do an initial assessment, and they put it into the context of what the player's been experiencing. They have a sense of what their workload has been, what treatment they've been having, and how the evolution may have occurred. And so they put it together and they create the context behind it. Usually have a discussion with the athletic training staff prior to seeing the player, and then we'll evaluate the player together. And often the evaluation concentrates on the ulnar collateral ligament, but we're also making sure that we're extremely accurate with the diagnosis. Accurate being that there may be other issues at play. There may be a bone spur in the back of the elbow that's hurting. There could be a flexor tendon that is responsible. Ulnar nerve issues come up. And some players have some level of arthritis if they're an older player, that it may not be that they have a failing ligament, even though the ligament with the next step of evaluation and physical exam and MRI and ultrasound may not look great. It may be another problem that's causing their symptoms, and they're getting by with what looks different on an MRI than normal. So accuracy of diagnosis we work on together. We do a physical exam, usually with a few people in the room. The exam includes range of motion, assessment of the UCL with palpation, moving valgus stress test. We bounce the elbow into extension to see if they have any bone spur issues in the back, check the flexor tendon, check their flexor forearm strength, palpate the tendon and the forearm muscles, and we check the ulnar nerve. In addition to all that, we see what's happening upstream from the elbow. Is there any issues with the shoulder, the back, their legs, their hips, etc., that may have changed and led up to it? And during that time, there's a little bit of atmosphere around the injury and some processing. But at some point, we'll look into if there's been any changes. A reliever may have had increased workload. A starter may be working on a new pitch. There may be some background on velocity enhancement that was taking place, new workouts that were introduced in the gym, some issues with back pain or something else in the kinetic chain. So we gather up all that information, and we have a very low threshold for imaging studies. And a pitcher or a position player, their elbow is, of course, so important to them that accuracy of diagnosis means getting appropriate imaging. So most often that's an MRI scan and x-rays. And we also occasionally do ultrasound. Ultrasound is great because the elbow can be moved in different positions during the exam. An MRI scan, your elbow is stationary. It's in one position, so there's no dynamic features. We're getting better with MRI where we can position it and put stress on it, which we call the fever view, which has been another advancement. And once we feel accurate with what the imaging tells us, we still have a challenge, and that is the thrower's elbow typically has changes in it, and our job is to determine, are the changes on MRI consistent and correlating with the symptoms? Because there may be incidental findings. An example is a player may have a bone spur, and if he had the bone spur for the past 5 years and hasn't been symptomatic and his exam is negative for a bone spur, then we don't attribute the pain to the bone spur. If the pain's localized to the flexor tendon, we just ignore the bone spur or put it into a framework of treatment where we're not emphasizing that as the problem that's holding him back. So with the training staff, we'll get a better sense when they start to put them through exercises, what's bothering them. There may be some things that they do within, their strengthening exercises around their shoulder or around their elbow that they say, hey, this is really sensitive for them. This is what he's getting. This is what bothers him the most. It's when he's in full pronation and he's gripping hard. That's when he feels it at the tendon attachment. And so the athletic trainers, they do such a comprehensive physical assessment along with the physical therapist, which is great. And occasionally we get the biomechanics people involved. Like, hey, we have a guy who's got a foot problem. Is he loading his foot in a different way? We'll get him in a biomechanics setting with a force plate and make sure that that's corrected as he goes through what could be a elbow issue that's compensatory for something as simple as his toe is bothering him and he's pushing off the rubber with less stride length, and now he's compensating with his upper body and his shoulder and elbow. So, I'll pause there because it's such a interesting evolution of how the injured athlete comes in and we go through the process. But I'll guess I'll say one more thing. Part of it is reading the player and acknowledging where he is with his emotion about this. Because some players can get very emotional, their elbow's hurting, they're fearing the worst, they're catastrophizing. And our job is to support them both physically, get their elbow feeling better, but also emotionally. You know, their whole life could be feeling like it's on a cliff right in front of their eyes. And other players are, they're at peace with whatever's happening. And those players want more of a direct approach. Just tell me what I got. Let's go. Try to get it fixed. Let's get it fixed. So
you make a really great point of how this has changed over the years from just an athlete being in front of you to now you have a really big novel of information and multi professions coming in together to really help with the diagnosis and the treatment plan and so now we're at this crossroads, right? We have all this information and we've taken diagnostics and we've done an outstanding health history and we've picked apart different movements and strengths and range of motions. And now we're at this crossroads of what do? We have obviously door number one is we treat it conservatively and we don't go to the operating room. And then there's door number two, which is, okay, we have a surgical procedure possibly on our hands. what's that conversation with the athlete? What's that conversation with the organization? And how do you approach it now versus maybe you did early in your career?
Yeah, great question. So, and I've published a little bit of research on this, which is really fascinating. In general, when there's multiple treatment options, we role play each treatment option so the athlete and everyone who's supporting the athlete, which could be family, their agent, some other people, coaching staff, they get a feel for what the different scenarios, how they play out. So the conversation will go like this. You have a partial tear of your UCL. The UCL has some healing capacity based on the degree, magnitude of the tear and the location. You also don't have an extensive history of being shut down with your elbow. You haven't had previous injuries. So those are favorable characteristics for healing. So I'll outline the favorable characteristics. The treatment A could be rest, rehab, possibly PRP injections, strengthening, return to throwing with a throwing program, optimization of mechanics. And if that works, you'll be ready in 3 to 4 months to be on the mound and starting to see hitters in a competitive fashion, maybe longer than that before you get into a major league game. And that's option A. If it fails, it can fail anywhere along that timeline. So you have to be prepared if it fails to go and step to option B or repeat A again with the consequence of lost time. And we're going to then evaluate how important time is. Option B is you get it fixed right away, and then we go over the multiple surgical options depending on what the tear type is. And some players are candidates for a repair operation, which is a shorter recovery. It could be 8-9 months before they're competitive. And that operation is sew the ligament back to its normal state. If it came off the bone, put it back into the bone, and then we put the internal brace in. And that's been great for some players to get back early. And then we would review Tommy John timelines and now the hybrid operation, which I'd like to explain a little bit more. But what we go with all this is some players will have an intolerance to failure of non-operative treatment. Why would they not tolerate it? Well, it could be where they are in their career. They only have so many years left. They're in their 30s. It could be contract related. They're approaching free agency, and they don't have a tolerance for failure of non-operative treatment. And the same goes with high school and college kids. They're looking to get drafted a certain year. They need to be healthy 2 years from now. They can't afford failure and be hurt a year later. And some don't have tolerance to miss 2 seasons. So the players who are getting hurt right now in spring, whether it's college or professional or high school, they end up missing this season, and potentially they're going to miss next season in large part. That's 2 seasons missed, which is really devastating and is unique to baseball because of the length of time it takes to come back from Tommy John surgery. So the discussion is, what's your likelihood of failure with non-operative treatment or success, and the timeline, and what your tolerance is for failure of non-operative treatment. And our research in questioning athletes of all different calibers, it now indicates that while non-operative treatment is based often on the predictability of it working, meaning if non-operative treatment has a high chance of working, players will elect that. More often than not, players will elect more aggressive surgery based on their intolerance to failure, and that's related to seasonal timing, where in the season it happened, and their career. And just to expand on what I mean by seasonal timing, if you get hurt in the fall and you have a trial of non-operative treatment and your elbow will declare itself, say, in December, you can still get surgery and be missing that upcoming spring season, but you'll be ready for the following. And so there's no consequence of that non-operative treatment if it fails. But if you get hurt in, let's just say, February, and you try non-operative treatment and your elbow doesn't declare itself as not working until June, well, you miss that season, and when you get it fixed, you're going to miss a good part of the following season. Now you have 2 seasons compromised. When that gets all played out on the calendar, players tend to say, I can't tolerate that.
Sure. And you brought up a new variation of the ulnar collateral ligament reconstruction, which is the hybrid technique. Can you go into a little bit more depth into what that is and kind of the advances that surgical procedure has kind of created?
Yeah, this has been a very special time in the world of Tommy John surgery from a technical aspect, because we're making the surgery stronger and the recovery is faster. And I'm going to describe the procedure, then I'm going to tell you about a patient. The procedure is we do a standard Tommy John surgery, but in addition to that, we repair all aspects of the native ligament. So whatever the injury is, we fix it as strong as possible in addition to putting in the Tommy John. And then on top of that, we put in this internal brace. The internal brace, it's like a seatbelt. It looks like a shoelace that gets fixed across the UCL, protecting it. And we do that for the repairs, but now we can also do it for the reconstructions. And it tends to make the reconstruction more durable. And what I'm seeing anecdotally, and I am researching it, is that there's less hiccups in the recovery, meaning players tend not to get as sore. They can get through the recovery a little bit faster and not have any need to have, say, time off to let their elbow, say, rest if they're putting a little too much stress on it. And I'll give you an example of what's been call it a enthusiasm for a faster recovery. One of the athletes that's not a baseball player that gets this injury frequently, but there's not as many of them out there, but they get this injury frequently, is the javelin thrower. Now, the jav thrower runs and hurls the javelin as hard as they can for distance, and the stress on their elbow with that heavy object causes their UCLs to get injured. And a typical javelin thrower takes longer than a Major League Baseball player to get back. They take 16, 18 months to get back. Now, I have a javelin thrower who needed to get back to continue their career in college in 10 months. And almost like Tommy John talking to Frank Jobe, he said to me, do something to get me back. And did the hybrid operation, the reconstruction, put in the internal brace, and he's back at 10 months throwing and achieving his personal records and hopefully surpasses them. And so that unique situation says maybe we can start pushing the recovery timelines with this hybrid operation. And you may say, well, why doesn't everybody just get the hybrid operation then? And it may come to that everybody gets the hybrid operation, but Tommy John surgery itself is already technically hard. Now when we put in extra tunnels and extra materials, it gets harder. And so the risk of complication can go up if the surgery is not technically done right. So it has to be done, in a very specific way. Otherwise, you can create new problems. And so this past week, I did about 12 Tommy John surgeries. 3/4 of them got the hybrid.
So that's a good point you make on looking at everybody moving towards a hybrid possibly in the future, and the return rates of those and the speed of return rate. What is the current literature suggesting for the outcomes for Tommy John surgery? Do you see that it's getting better, it's getting worse as players are throwing more and it's becoming more common? What does the literature say? But also, what do you feel and what are you seeing as a leader in this field?
Great question, Corey. It used to be that Tommy John surgery always worked from a feeling. And then the literature would say if the criteria is you get back to playing, it's a 85 to 90% success rate. But getting back to play is not always the metric that people are interested in. It's getting back to your previous performance. Getting back to play is one thing, but are you the same player as after the surgery? So the results of return to previous performance are more like 65 to 70% that you're the same player with respect to your performance metrics. So that's a little more sobering. Some players will get back better. It depends on where they are with their evolution. If they're younger and they're naturally going to get better, we keep them on their pathway. And in fact, a study that we published, if you're a drafted player into professional baseball play and you've already had Tommy John surgery, you tend to progress to the major league level faster than players who have not had Tommy John surgery when they're drafted. So there's something enthusiastic about the results of Tommy John surgery, even if you're a young player and you've gotten the surgery before you convert to being professional. And so the results now, as we get more and more fine-tuned with our analysis of players, are going to be more and more critical. And we're going to look more at longevity. How long does the surgery last? And because even with Tommy John surgery, we're not seeing it last forever. We got more and more guys who are getting what we call revision Tommy Johns, which is they had Tommy John once, and now they're getting it a second time. An example is Nathan Eovaldi, who was with the Yankees when he injured his ligament for the second time. His first Tommy John was at the age of 17. A second injury occurred when he was at the age of 24. At the time, he was one of the hardest throwing fastball pitchers in Major League Baseball. And 7 years on a guy who throws 101 miles an hour seems reasonable. We'd like it to be longer. He did not have the hybrid, but we know that second-time Tommy John surgery can be effective. He had the second-time Tommy John surgery, and now he's with the Texas Rangers and was fortunate enough to be part of a championship World Series team. So more players are opting for second Tommy John surgery, and in a good way, we're seeing the results of second Tommy John surgery improve. And initially, second-time Tommy John surgery was thought of to be a career ender, like it was a coin flip if you would get back. Now we're getting back players better and more predictably, which is really great because it's to go through a rehab twice, go through all of that, process of surgery all the time in the training room and not have it work a second time can be devastating.
Absolutely. Unfortunately, I've seen that happen, and it's not a great situation. But obviously, with the skilled surgeons that we have now, and you keep alluding to this long path, this rehab path. Obviously, the best surgeons in the country always have a strong relationship with their athletic training staff and their strength and conditioning staff, and everybody in the support of this athlete returning. So what conversations do you have with your staff once the surgery is over, once the player is through the initial phases of recovery, and now he's being turned back over to, say, the Yankees medical staff and strength and conditioning staff? What kind of oversight do you have? What conversations do you have? How much communication do you have with that staff to ensure that you obviously are the architect of the procedure is happy with the final outcome?
Great question. We're fortunate enough in our Yankee medical staff. We have such experts. They communicate well. We have mechanisms for communication through our medical messaging system. So we get constant updates on where people are with their recovery. How many throws did they make, et cetera, and how they felt that day. So we have systems in place for communication that are great. And we also have coaches that are specific to rehab pitchers, meaning the pitching staff that's working, coaching staff that's working with them, they're specific to the rehab process of players who are coming through it. And we also have biomechanics work at play. So the complement of these, all of the factors require communication. And we even have people whose job it is to make sure that the communication is going well so that everybody's aware. So if a massage therapist is working on somebody, they know what the strength and conditioning goals are, et cetera. And that communication is essential. I am also fortunate that while my skill set is in rebuilding the ligament, there are the team is composed of people who are experts in the rehab process. And so when people fall out of range of things that make sense, they're a little too stiff from a physical therapy aspect, they call me right away and let me know. And then we work on getting motion back. If somebody's having a mechanical flaw or after Tommy John surgery, their shoulder is getting sore, where we get biomechanics people involved right away during assessment. So we always are ready to manage anything that can cause a deviation from what would be a great rehab process. And that's having the right people on the team and having the right communication within the people.
You're right. You can never communicate enough in this process. And I can remember as a young athletic trainer, the first time having to go through being the person rehabbing a Tommy John surgery and just not knowing where to turn or where to look for the right answers. I remember Ron Porterfield was such a great asset to me to help me and gave me advice and little nuggets of wisdom. So what do you like to tell, young athletic trainers, physical therapists, or even surgeons? What kind of advice would you give them that when they're embarking on their first run of working with a post-op UCL? Because obviously a lot of our audience is student athletic trainers and student physical therapists that are looking to get into this field and into professional baseball. So what advice would you give them on the process of returning an athlete?
Yeah, great question, Corey. I like the idea of having cross-checks. Cross-checks are, let's have more than one person assess and agree if there's a little bit of controversy or some level of inexperience. I get asked a lot by young doctors how I got the Yankees job. Hey, how'd you get the job? And my answer to them is, why don't you ask me how I keep the job instead of how I got it? I love talking about how I got it, but how do I keep the job? I was fortunate enough when I first started that whatever the injuries are and the players that I was dealing with, I would communicate with other mentor doctors and ask them for advice. Lou Yoakum being one of them primarily. And Lou Yoakum, I mentioned, the team doctor for the Los Angeles Angels, I would ask him for, hey, I got a guy who's got a bone spur and he's 30 years old and he wants to get back this season, but he's real hot right now. And he'd say, well, what are you thinking about doing? And I'd say, well, I'm thinking about getting him an injection and we'll try and get him through the season. And at the end of the season, reassess and maybe we scope it. And he'd say, that's what I would do. And I'd say, hey, can I send you the pictures and you take a look and confirm? And when I'd see the player, I'd go over it with him. And then I would even tell him, I'd say, hey, I reviewed this with Lou Yoakum, and everybody had so much respect for him.
Sure.
The players be like, wow, you really did that for me. You went extra to make sure that what you're seeing is consistent. So call that cross-checks. And, when you're on a plane and you hear the pilot say, prepare for landing and cross-check is he's asking the flight attendants to cross-check each other's maintenance of the equipment, that it's stowed properly and everything's locked and all of that. They all cross-check each other. And before we start an operation, we do a cross-check that we're operating on the correct extremity. And that means that you have to have a certain amount of humility, because the people who get into the biggest trouble early on in their career is that they don't want to make a mistake or be perceived as making a mistake or unknowledgeable, so they don't ask for help. And when you don't ask for help, that's when you get into trouble. So in the medical community, I'm sure it's the same for you. If you're a young athletic trainer and you're going to rehab your first Tommy John, you should be doing it alongside with somebody who's experienced and they make sure that you're doing it properly and optimized. And with every subsequent Tommy John, you get a little more autonomy, and before you know it, you're teaching the next person.
Yeah, that's a great way of dissecting that, because that really is how it works, isn't it? It's just, paying it forward, and by the time you figured out how to do some of this stuff, it's now time to pass it on to the next person. And to that end, I'd like to close with giving you the floor one last time, and I know that UCL reconstruction, Tommy John surgery is in the news far too often today, and not just for the professional athlete, and that's what's most concerning. So what message would you like to give to our listeners, to parents, to coaches, to teams, but more importantly to athletes about this procedure, the dangers and some of the issues that we are seeing in today's baseball, and kind of what message would you like to give everybody?
Well, Corey, that's such an open-ended question. I'm going to describe a story where the Yankees were slumping. The team was slumping. They lost 5 or 6 games in a row. There was a time of the season where losing that many games was a problem. And a team meeting was held. And I actually was invited to the team meeting. And in the team meeting, there's lots of stuff that's being mentioned about the problems with the slumping and how we're going to get out of it. And Derek Jeter said something that resonates with me, and I try to incorporate it on a regular basis. And that is, you guys are making too much out of this. You got to go out there and have some fun. And the reason why that's important is because we're caught up with the competition, the winning of games, the media, the social media, the way people think about us, the way people view us. And we need to remember on every level, including the youngest level, that we're here to play a game and have some fun. And I operate on Tuesdays. The hospital that I operate on is adjacent to the soccer field that I played soccer at during my college years in Columbia. And before I start operating, I go to a window, I take a picture of the field, and I remind myself of what a privilege I have this day to take care of athletes and get them back to the game that they love. So it's a real privilege to do what I do, and I hope that players and the athletes, that they get to enjoy the ride and make sure that the pressure and the stress that goes along with it doesn't take away from what could be some of the greatest joys that they'll experience in their life. And that is taking on the field and playing the game that they love.
Well, Dr. Ahmad, it was an absolute pleasure and honor speaking with you today, and thank you for your insight and for all of your knowledge on Tommy John surgery, and hopefully you can now get back to fixing the next wave of superstars in the game.
Well, Corey, I can't thank you enough, and everything that PBATS does in support of the health of baseball players. And thank you. This has been terrific.
Thanks for listening to Inside Athletic Training's Tales of the Tape, the Tommy John series. Make sure to tune in next week as we sit down with Ron Porterfield of the Los Angeles Dodgers to discuss the rehab process after Tommy John surgery. And for more information about PBATS, please visit pbats.com.